Sorry for the radio silence. The last month or two, I have been rather busy writing a book. Anyway, last week I had the great fortune to have a long chat with consultant cardiologist and electrophysiologist Dr Boon Lim, who is clinical lead for the Imperial Syncope unit at Hammersmith Hospital. If you've got a question about dysautonomia and tilt tests, you really couldn't find anyone better to ask. There's absolutely loads to talk about on the subject, so I'm going to break it up into a trilogy of 3 films. In this first film, we're going to talk about dysautonomia, which long COVID symptoms it can be responsible for, how Dr Lim treats it in his clinic, and what the hell is going on when we wake up in the middle of the night with a racing heart. In the next film, we dive into the fascinating world of tilt tests and how they give us a window into the physiology of dysautonomia. What's actually involved in having one? What can you learn from the results? And do you actually need one to be able to get a handle on dysautonomia? In the third film, we're going to talk about HRV, why it's so relevant for long haulers, what we can do to improve it, and what it means in terms of managing our symptoms and possibly even aiding recovery. So could we just start with something really simple? And that is to describe what dysautonomia is in simple terms.
So dysautonomia is a term that describes a disorder or dysfunction of the autonomic nervous system. And I guess there are 2 ways of thinking about it. Your autonomic nervous system is that bit of the nervous system that controls all the activities we don't consciously think about, subconscious or unconscious control. Things like heart rate, peristalsis, blood pressure regulation, temperature regulation. And these things are normally automatically regulated quite finely. So it generally isn't much of an issue. Now, any one of us, including those who don't have long COVID, can have a dysautonomic profile. For example, after you've had a lot of alcohol, say on a night out for your birthday, and you wake up the next morning, you haven't had COVID, you haven't had a virus, and you can feel a little bit rough. And this is where things like the kind of Aura ring or your Apple Watch might tell you your readiness score or whatever that score is a bit low. And so the autonomic nervous system, I don't want to imbue too much, if you like, illness or a feeling that this is something that is an all or nothing phenomena, i.e. long COVID, dysautonomia, screwed for life. It's something that on a daily basis, and sometimes even on a minute-by-minute basis, will fluctuate. And sometimes when it fluctuates in an exaggerated manner, you can call that transient dysautonomia. So my view is that dysautonomia is a fairly normal process that can hit any one of us, even in the absence of a viral illness, for some amount of time when there's a particular trigger and a susceptibility. And of course, what the viral illness does, whether it's long COVID or glandular fever, is it can then provoke a worsening or an exaggerated autonomic dysfunction or autonomic nervous system that activates in a way that causes a whole constellation of symptoms. And I'm sure we'll expand on that shortly.
So, I mean, this is interesting because my feeling is that dysautonomia as a consequence of long COVID is not something that we're necessarily going to be stuck with forever, because my own experience of it and other people I've seen is that it does fluctuate. And there may be days where actually I'm quite tolerant and I can do all sorts of things that on other days I couldn't do. One of the things that David Petrino said on Twitter recently, which I agreed with, because that's my experience too, is that there's almost this clunking that happens between okay function and then suddenly bang, sympathetic nervous system activation, and then suddenly CLUNK and it can clunk back again. I don't know if that's sort of, rather than a smooth transition between parasympathetic and sympathetic, there does seem to be this dial that kind of does that. Is that something you've witnessed too? Does that sort of ring a bell for you?
So I've witnessed on both states, really. And there are some patients who recognize to the hour or to the day that the symptoms started to get worse. And oftentimes it is on the background of a significant stressful event. And now when I say stress, I don't mean mental stress. It could be any challenge. So for example, if you think you're recovering from COVID, 3 weeks have passed and you think you've got over it, you go for a 5K run. That could be the tipping point, following which you trigger some kind of clunking, as you say, or a transition step, which is quite a large step in your autonomic state. And thereafter, you find it very difficult to recover for a week or two after that 5K run. And if you try another 5K run after 2 weeks, you step down even greater. So I think a lot of what you've discussed in your previous webinars, Jess, including the pacing, the recovery, taking it nice and slow, is part of an intuitive body listening exercise that we need to learn. And I think this is one aspect that we don't do very well, or people with long COVID don't tend to have that interoceptive ability to recognize when they're at the incipient or threshold stage of clunking. Because the clunking doesn't happen just like that. You need a few risk factors and certain preconditions to push you to the state at which you can clunk. And then it happens. You do something which it may not seem stupid at the time, like going for a 5K run when you are typically going for 10K runs prior to COVID, may not seem like such a big deal, especially if you wake up fresh and alert, good night's sleep, Sunday morning, well hydrated, you do it, and then you step down, and then you kick yourself. So yes is the answer, but I also want to qualify that by saying that the other option is also possible, that some people have a gradual deterioration in the autonomic nervous system function. And I particularly like what you've done previously in your previous webinars when you talked about the impact of previous trauma or the kind of personalities that may be susceptible to having a relapsing, remitting long COVID experience. Because in my own view and experience, this is something that comes across time and time again. The likes of you, Jess, who wants to push it skiing whilst recovering from long COVID and seeing how far you can push it. And I think you got away with it quite nicely, but other people may not.
Yes. Yeah. And for me, I wouldn't have got away with it had I not added a set of other behaviors to compensate for the activity I was doing and modifying the activity the way I was doing it. So short, 20-second skiing, stop, breathe, ski a little bit further, stop, breathe, and even only an hour in total in the day, as opposed to what I would normally have done is just cane it from the top of the mountain to the bottom of the mountain.
But that needs to be repeated, Jess. You need to tell people that you're not skiing 8 hours like you used to.
Yeah.
You're skiing for 20 seconds. And just tell me about the breath again, because that's phenomenally interesting. What is the breath?
So basically what I try and do is I mean, skiing naturally, if you're skiing with a group, you would tend to ski a distance and then stop and wait, ski a distance, stop and wait. And I was simply shortening those distances. And in the points of time when I wasn't skiing, I would very consciously slow my breath down and do coherence breathing, 5 seconds in, 5 seconds out, and make sure I was doing that in every 1, 2, 3, 4 minute period I was waiting between each skiing segment. And on every lift I was getting on, suddenly now you're sitting down for 5, 10, 15 minutes. On my entire lift, I would just sit there and just focus on my breathing and try to not get sucked into the conversation that was happening around me, but just focus on the breathing. So again, I was just calming things down in compensation for the fact that what I was doing was very stimulatory otherwise.
Yeah, so I fully agree that this is the way that people should pace when they get back to exercise. And to your point earlier on, when you asked me about clunking, you don't always have to clunk in the wrong way in terms of sympathetic activation. What you've demonstrated there is you can clunk the other way. Yes. So you can automatically reset or actually recalibrate your parasympathetic nervous system and increase the expression of the vagus nerve by doing exactly what you've done, a 5-second breath in and then a 5-second breath out. And on a continuous basis, if you can breathe like this, particularly through your nose and into your belly, so this is belly breathing or diaphragmatic breathing, I think it's a particularly useful way to activate the vagus and dial down the sympathetic nervous system. So don't ever underestimate. In fact, it is crucial to the recovery of patients with long COVID to really focus on breath, particularly nasal belly breathing. And I think that's why some long COVID recovery groups or exercises with either respiratory physio or even, say, the English National Opera program, ENO Breathe, have had some success. Some yoga studios have opened up rest recovery programs such as Susie Bolt, and there are several other yoga programs. And the focus for all these programs is centered around breath work. I mean, there are other things, including pacing and important holistic strategies, which I fully believe in, but breath work is the central tenet by which you can reduce the expression of the parasympathetic nervous system.
So another example of pacing where I do try and activate a clunk in the other direction is even sitting at home and working at my desk. I'll do perhaps 40 minutes. If I'm really lucky, I might manage to stretch for about 40 minutes at my desk. And I notice at that point that my cognitive, it's weird. I start to feel that my ability to process information becomes compromised. I can go and lie down. I put on my alpha stim, so electrical stimulation, theory of a, slows that long wave stimulation, something like that. And I'll lie down on the sofa, I'll close my eyes, trying to remove as much stimulation as possible, do the coherence breathing. And what I find often happens really quickly is I will trigger a series of very strong aggressive yawns that come through. And after that 10-minute period, my eyes are watering, the yawns are attacking. And that feels like it's a clunk back in the other direction, back towards a parasympathetic. Once I've done that, the heart rate's about 10, 15 BPM lower. And my head is clear and I can think again, and I've got another 40 minutes clear. And that's how I manage my working days.
So can I share that one of the things that I've always wanted to study in greater detail is the physiology of yawning, because, oh my goodness, do we see people yawn a lot during tilt, particularly, I mean, if we have time, we can talk about the tilt data, which I can demonstrate your own tilt data, but the yawning that occurs in people who are not otherwise sleepy, but the opposite, people who are adrenergically driven or sympathetic nervous system overdrive, is so marked sometimes. And in the context of that sympathetic overdrive, they start yawning. And I think yawning is a very, very complex physiological process. And, the Dr. Seuss sleep book, if you've ever come across it, is a great way to get your kids to sleep. Because I guarantee you, by the time you're halfway through the book, both you and your kid will have yawned at least 5 or a dozen times, because it is that kind of looking at somebody else's yawn can trigger a yawn in you. But in this particular case on the tilt lab, and certainly what you've just described, I think yawning triggers a physiological reset, if you like. I can't really prove it yet, but it's one of the things that I have observed as an interesting thing that's seen during tilt, during sympathetic.
There's an argument I read somewhere about how actually the process of yawning creates pressure on the vagus nerve. So it's a sort of an action that the body takes to try and push the body back into a parasympathetic state. That was what I read, and it seems to make some sort of sense, right?
Yeah, so it makes sense, but if you think about respiratory sinus arrhythmia, the maximum variability in the heart rate profile, which is your respiratory sinus arrhythmia, and that's what HRV is. Heart rate variability is the extent that your heart rate varies between the nadir, the trough, and the peak over a respiratory cycle. So if you take a deep breath in and you take a deep breath out and you monitor your pulse either in your neck or your wrist, and your audience can do that now, particularly if you follow a slow cadence, which is said to be a coherent breathing pattern. The ideal breath, as James Nestor says in his book, Breath, which is there, is a phenomenal way to activate your maximum HRV training. And this we can show very clearly on tools like HeartMath. And so this is something that actually, with the biofeedback that you get and your regulation of your heart rate variability, can help to activate the parasympathetic nervous system. But it's often thought that it's due to the mechanisms, not only pressure in the vagus, but intrathoracic pressure expansion and contraction, lung volume expansion and contraction, and therefore the volume of blood in your heart expanding and contracting. And they are very sensitive, both chemoreceptors and baroreceptors. But I think for yawning, it's not mainly the chemoreceptor, because it would take too quick for you to change your CO2 levels or oxygen levels, but more like immediate stretch, because the stretch receptor is quick, and the stretch receptors are available for action and reaction in the lung, in the aortic arch, and in the baroreflex, which are here. And that can be activated just like that. So yawning resets those stretch receptors that then give a very complex feedback loop into the primitive brain, which then alters the outputs, which are vagus and sympathetic chain. And depending on how much your vagus is pulsing up and down together with the sympathetic chain, that dictates your HRV. So it's complex, it's wonderfully complex. And I would say it's so nice to see this physiology every day in the tilt lab. It's just that the too many variables in the tilt that when your sympathetic nervous system is yo-yoing and activating, the yawn doesn't really touch it all that much. So trying to demonstrate a clear delta is a bit more difficult. So we need, I guess, more control conditions. And it's always been one of my dreams to do a Dr. Seuss sleep book tilt table test control in a normal subject to see what the physiological impact of the yawn is.
Absolutely fascinating. Let's say you've got two types of patients who present to you, one like me who presents with dysautonomia but not necessarily POTS, and another who presents like one of those other tilt tests you showed, which have definite POTS as well as dysautonomia. How do you go about treating them? What are the first things that you advise in terms of behavior, and is there anything that you go down in terms of medication?
So I would suggest that there is the ability to deploy a whole lot of conservative strategies. So this is my kind of website, which is at the moment charitably run and kind of created on a Sunday morning with my co-conspirators pro bono. But there's one particular autonomic dysfunction sheet that you could download freely from the website. And it really talks about top tips for improving autonomic dysfunction in long COVID. So I don't like to start off with drugs, and that much I will say. I like to start off with a very clear diagnosis. And I don't want to pretend that there aren't other multiple diagnoses or mechanisms for long COVID that you've covered very much and very well in your other talks. But if the patient has got worsening symptoms on standing and improving on sitting, and that is a prevailing feature, the palpitations and everything else we talked about, then I'm going to, for a moment, forget about mast cell, immune activation, viral debris, platelets, and all this other stuff. I'm going to forget about it, because if those were true, then when you stand up or you sit down, those mechanisms would still be at play. So this is specific for the patient cohort that I'm talking about, autonomic dysfunction. And I recognize that this is a cohort that obviously I'm biased in my experience, because when they are referred for a tilt, people are suspecting it. So it tends to be manifested in the tilt data. But that being said, that caveat being said, I would say that fluid increase, because most of these people have got low or low normal blood pressures. But with the exception of the tilts that I showed you, okay? If you are going to be doing an activity, particularly exercising, consider salt intake or consider an isotonic effervescent tablet, which is the isotonic isotabs that you can put, and it fizzes like a Berocca does. Not Berocca, something like Noon Precision 1500 ORS, these kind of tablets. Consider wearing compression stockings, which should be lower limb compression to the thigh or to the waist or abdomen. And if you like, there are consumer grade stockings, sporting stockings that are pretty compressive, such as Skins. But then there are other stockings which are medical grades, such as Bauerfeind, Sigvaris, Gardamed. And these are stockings that you could wear, because if you think about the physiology, you're pooling blood, right, in your lower limbs. And what you like to do is squeeze externally. So the stockings give you some external squeeze. And then the internal compression is quite helpful, where you learn to perform isometric counterpressure exercises. I don't know if you've ever done this, Jazz, but just squeezing your glutes, your quadriceps and your calves can immediately give you that boost. So if you're flagging a bit now, Jazz, try and just squeeze your buttocks, squeeze your calves and your quads. You see, I'm bouncing in my chair. And just by squeezing, sometimes you see a sharpening, because what you're doing is you're returning the blood parked away in the huge reservoirs, which are your lower limbs, back into the heart. So that could work. And then this is the bit that you already talked about, and I'm glad you raised this, not me. Slowing your breath down to 5 or 6 seconds in a sinusoidal pattern, because then you activate or you clunk into vagus. And then my view is there are two approaches. One is the bottom-up approach, where you engage and entrain physiology. In my mind, the autonomic nervous system facets, of which we said peristalsis, blood pressure, breathing rate, temperature, sweating, pupillary dilatation, a lot of that is not under your control, apart from one, which is your breath. So the breath, I think, is a very, very nice shortcut, or the only way inroads into the autonomic nervous system to which we can apply our own effort. So physiologically, we take control of our breath and we entrain it to the perfect breath, which is 5 or 6 seconds for most people. And that gives you more vagal expression. But the other component that expresses higher positive autonomic balance, and in particular more vagus, less sympathetic, is actually coupling that breath with a positive emotion or thought. And the easiest to elicit would be something like gratitude, but compassion, love, forgiveness, these are also other emotions that you could bring into play as you're focusing on the breath. And the focus on the breath without ideally any distracting thoughts about what's happening in the future or how the day is going to be or the past thoughts of anxiety is the way, I think, the best way to try and recenter your autonomic nervous system by yourself. And this means living in the present moment. And what better way, as you know, to be in the present moment than to just focus on the air, the healing, kind of nurturing air coming in through your nose into the deep recesses of the lungs in a 6-second breath and coming out. So that is my bias in terms of treatment, which is a more conservative, stepwise, not stepwise, but a conservative lot of treatment. There are pharmacological agents that I will use in some patients. And in you, Jess, if you were my patient, I guess you came for a tilt, but you weren't referred to me. But if you were my patient, I would ask you how you're getting along in day-to-day life. And I would see you as a highly functioning patient when you want to be, or when you're not misbehaving, like going to Thorpe Park all day or skiing without a break.
Yeah.
And this kind of behaviors that are necessary for enjoyment of life sometimes should be forgiven by yourself. Yeah.
Yeah.
So you've gone to Thorpe Park. Don't regret a crash that you're experiencing now. In fact, embrace the fact that you enjoyed Thorpe Park yesterday, and today you'll sleep it off or rest or recover, drink lots of fluids. And you know what? You'll be better tomorrow.
Yeah.
But you have to forgive yourself. And this is also part of that state that we talked about, the psychological state that, oh, damn it, I did too much. And now I'm back on. That is also a very autonomically unhelpful state of mind to be in.
Completely agree.
The mindset actually affects the autonomic a lot more than we think.
Yeah.
So that being said, Jess, for you, if you had done your fluid dissolve, your compression, your mindset, you didn't go to Thorpe Park every other day, and you were still symptomatic, then I would give you a drug to augment your blood pressure, something like midodrine, which is an alpha blocker, which is something that vasoconstricts your splanchnic or the blood vessels in your gut, or the peripheral vascular system, which is your lower limbs. It would constrict that, return blood to your heart, and improve blood volume, improve blood pressure. Or fludrocortisone, which is a mineralocorticoid, which serves to reabsorb more salt at the level of your kidney, and again, expanding your plasma volume and not allowing this push or this pull, gravitational pull to occur. So that is what I would suggest in terms of the guidance from tilt testing, because the tilt testing will give me an idea whether you're low or high blood pressure. If you're high blood pressure, I wouldn't give you midodrine. If your high blood pressure is the dominant symptom, and not dominant symptom, but the dominant physiology, together with palpitations as your dominant symptom, or maybe chest pain, I might give you something to slow your heart rate down. So this is then guided by the tilt. Because I don't want to give you midodrine, your blood pressure is already high. I give you propranolol, which is a non-selective beta blocker in a low dose, something like 10 to 20 milligrams twice a day. Or I give you ivabradine if I'm concerned that I don't want to push your blood pressure down, because propranolol can reduce your blood pressure a bit. But generally, propranolol and ivabradine, by the way, is 2.5 milligrams twice a day. These are the drugs that we would give for patients predominantly suffering with tachycardia on standing. But it can also have a very calming effect. And then very interestingly, interesting for me is that those patients who have palpitations at night, and I'm seeing quite a lot of them who describe palpitations in a day, but also palpitations at night. And you might ask me, why, when you're lying flat, do you activate the autonomic nervous system? There's no reason for it, right? Because you're not being tilted and you're not sleepwalking. And the answer is, not the answer, but in my anecdotal experience, I think there is a degree of overlap between the mast cell stories. So as I said, I'm open to other theories. And in the realm of mast cell degranulation or histamine intolerance, what we get is a spontaneous release of histamines at night, which may be triggered by a dream or may be triggered by just the ongoing insensible losses at night. Insensible losses means when you produce urine, you sweat under the sheets, you're breathing, you're not drinking anymore at night. And so the blood pressure tends to fall, triggers an autonomic nervous system surge. Whilst getting dehydrated, mast cells suddenly degranulate because it's reached a critical point, because one of the sensitizers of mast cells is a heightened sympathetic nervous system. Then you suddenly get a pooling, like this is a CLUNK occurrence, because it's not like gradually getting tachycardia. You wake up and your heart is racing. Those patients can do very well with a nocturnal antihistamine or even BD antihistamines. And I don't mind a H1 and H2 blocker. And I do prescribe this in my practice as well with that specific syndrome profile, but also if you get a rash and hives and all these other more typical features of mast cells.
I hope you found that discussion as enlightening and fascinating as I did. Next up is going to be the film on tilt tests, where we go through my results as well as a healthy control and 2 other long haulers and see exactly what's going on in terms of malfunctioning physiology. Until next time.